I don't know how much of it's a warning or a question or a comment. I'm a systems guy, so I look at a lot of data and over time, and when I see ranges of a common measure like ROI going from 1.9 up to 14, that's like 10 to 1, and that says to me we don't know enough about what's in there. So one of the things for everybody, and I liked seeing in the last presentation, you're really defining a population that's fairly consistent so that you don't have medication issue variability in there and so on. You've got the similar sociodemographic status and so on, but you still have a range of mild, moderate, and severe clinical risk and so on. What I'm hoping to see more and more of as we try to evaluate evidence from elsewhere, particularly putting into that database, is how did the study really in detail define the population that they're looking at in terms of clinical risk strata, sociodemographic risk strata, poverty, et cetera, and then how did you put them together to come up with that ROI? And so I've seen from looking at data in projects that we've done, what answer do you want? If I can vary the targeting, I can vary the ROI. And so not having context is an issue. So I guess I'm calling for context in everything we see. So if I'm an investor, I'm going to be skeptical. And just telling me there's a return, I want to make sure I get it. Because as soon as we get a social impact bond that doesn't have a result, it calls into question the whole potential there. So let's make sure that we have, if you're doing visits, how many visits, what's the cost, how, if you're in a situation where you might have IPM and additional education and additional medication adherence and everything else, who knows how much each one is, but at least if we have a description in all the data, we'll be able to start teasing things out.
Those were great, excellent points. Love that. So for our Healthy Homes technical study, for example, we are, and I guess first to the ROI question, I think one of the aspects of the reason why you see such a wide range in ROI for some of these interventions is the costs are very highly differentiated because of the service. So you can have an asthma home intervention that is 1 or 2 visits by a community health worker, and they'll show results. Or you could have up to an intervention where you're doing roofing repair, and so I think that's one factor. But definitely getting to the actual details of the range of interventions is so important. So for our study, for example, we're doing claims data matching, looking at sort of 2 groups. So we have sort of an intervention group that is just home visiting and IPM and education, and then a second group that is the higher cost sort of interventions, the structural interventions. And so and we're looking at the profile of the claims and the changes in medical utilization, so that we can try to sort of tease out those results. Mm-hmm.
I couldn't agree with you more. There's a lot of heterogeneity in the data and how those returns on investments were calculated. So I think the high-level view of ROI is a good starting place to maybe pique interest and start the discussion, but it definitely, to move forward practically into action, definitely takes talking about specifics. And that's definitely something we've learned talking with payers that we've been starting to talk to through the policy offices, that we've heard don't just tell us you want, for example, a home visit program. Tell us how can we build on what we're already doing? So thank you.
I'm sure there are other questions from the audience. One question that I had, Michael, you mentioned a lot of partners in your effort, and here we are at the table and in the room with a lot of state and federal public health partners. Wondering where there's room for partnership with public health in your efforts, if they're part of what you're doing, how can people in the room be thinking about social financing as a new model, and how can they be part of that?
Yeah, there's a lot of players that are at the table in any of Pay for Success or social impact financing deals, and so I'd say that one of the first things to do is to sort of reach out to those stakeholders. So when we had our investors, it was kind of interesting because we had our investors come to us first, and so our first meeting was with Hopkins Healthcare, who we've worked with for years and years. Then our second visit was to the State Department of Health and Medicaid to say, look, we're going to explore these projects. And then our third meeting was to our local county Department of Health to sort of talk about which interventions and resources they were doing. And in our 5 studies where we're trying to replicate this model, we're sort of specifically sort of reaching out and having sort of bringing together all the stakeholders and keeping them abreast of the project and working on ways in which they would be engaged either as a service delivery provider or providing access to data or being part of the evaluation. And so it's a lot of folks to get together, but it's critical and important. And anyone that's thinking about exploring this, I think that's one of your first steps.
Another question I had was for. Oh, did you have a question?
I think this is to Michael, but it might be in the audience. The one question I had is, how much risk is there a willingness for pay-for-success models? As we talked about, asthma's complicated, and it isn't that predictable, even with these interventions. So the question, I guess, is, when there is these discussions with finance folks, how much risk are they willing to accept? Because I think there probably is risk. Sometimes these things aren't going to work. And then the other one was, can everybody do return on investment, or do you need specialized? I think the fact that CDC is giving more information on how to do these calculations, but is this something that everybody can do, or do you need to sort of collaborate with others to do this work?
Yeah, looking at the risk to the investors in most of these projects that have been launched, and there's only been 8 of these social impact bonds or pay for success projects that have been launched in the country so far, and they've and there's probably about maybe 80 to 100 that are being explored right now, but. Trying to mitigate that risk on investors is a key aspect of this model, especially early on. And so for most of the launch projects, they are backed by philanthropic funding to do risk mitigation. So I think actually the first one that was launched, it was in New York. It was focused on prison recidivism. It was on Rikers Island, and the investment was made by Goldman Sachs. But about 70% of the funding was backed by the Bloomberg Foundation. And that project actually was not successful. So the intervention was, there was an independent evaluator and determined that the counseling program that was basically used at Rikers Island was not able to reduce recidivism. And so the state did not pay back the investor, and so, but Goldman Sachs, ended up only losing 30% of the upfront investment. So.
My question, generally, I think for all the panelists, as you're thinking about describing return on investment, a complaint or a comment I sometimes hear from folks is that when you lump it all together, that we save healthcare costs, but we also save missed school days and caregiver missed days of work, and you calculate all of that return together. It can paint a really rosy picture, but for investors, they're going to really be interested on their return to them, and so the savings that accrue to the community as a whole aren't maybe as convincing as specific savings to them. So just sort of wondering, about the CDC's work and other work in terms of dissecting what's in that return on investment, making that really clear for different parties and stakeholders.
Sure, thanks. I wholeheartedly agree. I think that part of the heterogeneity in what's been reported is some ROIs contain only healthcare utilization, and some include basically savings from missed work and school days. So I definitely echo the call for transparency, to be transparent about what's included. Is it healthcare utilization or something else? And I think the ROI that you present in your business case, I would think about what does your audience want to hear. So if it's a health plan, they might be interested in missed work and school days, but they might be most interested in the claims, the medical claims that the change in medical claims that they should expect. Whereas if you're talking to an employer, a large employer, and talking to them about your proposed intervention, they might be more interested in how does this improve or decrease work absenteeism or caregiver absenteeism because of a sick child. May I make, one plug, something that was just launched yesterday kind of in our efforts. I've heard a lot about trying to engage health plans in the discussion today, and I'm really excited about that. The CDC has launched an initiative called the 618 Initiative, and trying to kind of engage states and work with states to engage payers, Medicaid, and others to advance reimbursement for home visits for asthma as well as other asthma control strategies. So you can find out more about it on www.cdc.gov/618. That's in text, so SIXEIGHT, et cetera. And this is an evolving website. There will be products published that you might be able to use, like more evidence syntheses for asthma and other documents. So I'll stop talking now.
I just wanted to add that I totally agree with your point earlier and also what you're raising. And I think to put on just my very data hat as opposed to the asthma part of everything, I think that a lot of this is about the communication of data. And one of the reasons that we've designed our study the way that we have is we fully intend to look at our primary outcomes, and then we have secondary outcomes. So to look at the utilization by itself, to look at things like missed school and missed work, and quantifying those with economists who can help us with those cost investments, and looking at, we want to look at population overall, so we're going to do controlling in our analysis for different levels of asthma and that kind of thing, but then we can also look within groups. We have a large enough sample so that we can break that down. And I would just put a plug out there that nobody should be presenting any number just by itself on a slide that says the return on investment is X. We always need to be quantifying that and saying, return on exactly what am I investing in and for what population. And I think that's always possible with every number if you can just find where the information is. So I would just put a plug out that that's feasible and we should be doing it.
Our project is also a return on investment analysis and cost analysis based on home-based data and claims data, not with a control group. But I think one of the challenges is when we have payers asking, what's the return on investment of this component? And so it's interesting, your IPM, I think it's really interesting. I'm looking forward to it. But I also think that it gets difficult when we start being asked to talk about what's the return on investment of this part of an intervention versus there's a package that goes together, and you can't do IPM without asthma education or other components as well. Yeah. It's just a challenge we think about.
No, I would say, you probably have a lot to say about that too, but I totally agree. And I think a big part of the vision that sort of was underlying this study in the first place was that there has been, and this community in here all know that there's been pushback about how much it costs to do a whole intervention or all of the pieces, and we in environmental health we're really coming at it from this very unique or very specific perspective of pest control. Like, we have this other problem that's bigger that we're trying to deal with, and we thought this is one mode that we can address that will also become a piece of this bigger picture of asthma interventions. And so we ended up doing this study because we couldn't find exactly this question, right? You look, there's many studies out there that are great, that are looking at all kinds of return on investment for in-home interventions, and they'll say, we did these, 15 things, and one of them is some kind of pest control, and a lot of times you don't even know what kind of pest control it was. And so that's where we are coming from. We were like, we need to be able to say, for this specific kind of thing, which we can make happen in the industry, the pest control industry, for this cost, this is what we can see for a return on it. And we believe that we really will see a return specifically for this piece. But I agree, like, as I said, it's never just one thing, and we always want to be acknowledging that this is only one piece in this bigger picture. So.
Did you?
I mean, just one little thing. I think, relative to Carrie's point around this protocol, what I see is that it's influenced our other work. That the protocol that we're using for the asthma study for IPM has influenced how we're asking the general building owners community when we're promoting IPM. That is really what we're doing here, is influenced the whole other work. So we can try to begin to change the culture of what's going on in the city. So it does have this ripple effect of creating something we really feel like could be scaled up, used not only for asthma, but also something slightly different for the bigger community when you're talking about what pest control should look like in the city.
Well, thank you all. We are at time. I really think we could have a whole day just on this panel, but thank you to our panelists.